Drug absorption and distribution. Unless a drug acts topically, i.e., at its site of application, it first must enter the bloodstream and then be distributed to its site of action. The mere presence of a drug in the blood, however, does not lead to a pharmacological response. To be effective, the drug must leave the vascular space and enter the intercellular or intracellular spaces or both. The rate at which a drug reaches its site of action depends on two rates, absorption and distribution. Absorption is the passage of the drug from its site of administration into the blood, distribution is the delivery of the drug to the tissues. To reach its site of action, a drug must cross a number of biological barriers and membranes, predominantly lipid. Competing processes, such as binding to plasma proteins, tissue storage, metabolism, and excretion, determine the amount of drug finally available for interaction with specific receptors. Properties of biological membranes that influence drug passage. Although some substances are translocated by specialized transport mechanisms and small polar compounds may filter through membrane pores, most foreign compounds penetrate cells by diffusing through lipid membranes. A model of membrane structure envisions the membrane as a mosaic structure composed of a discontinuous bimolecular lipid layer with fluid-like properties. A smaller component consists of glycoproteins or lipoproteins that are embedded in the lipid matrix and have ionic and polar groups protruding from one or both sides of the membrane. This membrane is thought to be capable of undergoing rapid local shifts, whereby the relative geometry of specific adjacent proteins may change to form channels, or pores. The pores permit the membrane to be less restrictive to the passage of low molecular weight hydrophilic substances into cells. In addition to its role as a barrier to solutes, the cell membrane has an important function in providing a structural matrix for a variety of enzymes and drug receptors. The model depicted is not thought to apply to capillaries. Physiochemical properties of drugs and the influence of pH. The ability of a drug to diffuse across membranes is frequently expressed in terms of its lipid-water partition coefficient rather than its lipid solubility per SE. This coefficient is defined as the ratio of the concentration of the drug in two immiscible phases, one a nonpolar liquid or organic solvent, frequently octanol, representing the membrane. 2 an aqueous buffer, usually at pH 7.4, representing the plasma. The partition coefficient is a measure of the relative affinity of a drug for the lipid and aqueous phases. Increasing the polarity of a drug, either by increasing its degree of ionization or by adding a carboxyl, hydroxyl, or amino group to the molecule, decreases the lipid-water partition coefficient. Alternatively, reducing drug polarity through suppression of ionization or adding lipophilic, example phenyl or T-butyl, groups results in an increase in the lipid-water partition coefficient. Drugs, like most organic electrolytes, generally do not completely dissociate, i.e., form ions, in aqueous solution. Only a certain proportion of an organic drug molecule will ionize at a given pH. The smaller the fraction of total drug molecules ionized, the weaker the electrolyte. Since most drugs are either weak organic acids or bases, i.e., weak electrolytes, the degree of ionization will influence their lipid-water partition coefficient and hence their ability to diffuse through membranes. The proportion of the total drug concentration that is present in either ionized or unionized form is dictated by the drug's dissociation or ionization constant, K, and the local pH of the solution in which the drug is dissolved. The dissociation of a weak acid, RH, and a weak base, B, is described by the following equations. If these equations are rewritten in terms of their dissociation constants, using K, for both weak acids and weak bases, we obtain by taking logarithms and then substituting the terms pK and pH for the negative logarithms of K and H, respectively, we arrive at the Henderson-Hasselbatch equations. It is customary to describe the dissociation constants of both acids and bases in terms of pK values. This is possible in aqueous biological systems because a simple mathematical relationship exists between pKp, pK and the dissociation constant of water pKp. The use of only pK values to describe the relative strengths of either weak bases or weak acids makes comparisons between drugs simpler. The lower the pK value, pK, 6, of an acidic drug, the stronger the acid, i.e., the larger the proportion of ionized molecules. The higher the pK value, pK8, of a basic drug, the stronger the base. Thus, knowing the pH of the aqueous medium in which the drug is dissolved and the pK of the drug, one can, using the Henderson-Hasselbatch equation, calculate the relative proportions of ionized and unionized drug present in solution. For example, when the pK of the drug, example 7, is the same as the pH of the surrounding medium, there will be equal proportions of ionized R and unionized RH molecules, that is, 50% of the drug is ionized. The effect of pH on drug ionization is shown in figure. The relationship between pH and degree of drug ionization is not linear but sigmoidal, that is, small changes in pH may greatly influence the degree of drug ionization, especially when pH and pK values are initially similar. Mechanisms of solute transport across membranes. Except for intravenous administration, all routes of drug administration require that the drug be transported from the site of administration into the systemic circulation. A drug is said to be absorbed only when it has entered the blood or lymph capillaries. The transport of drugs across membranes entails one or more of the following processes: 1. Passive diffusion. 2. Filtration. 3. Bulk flow. 4. Active transport. 5. Facilitated transport. 6. Ion pair transport. 7. Endocytosis. 8. Exocytosis. These processes also participate in the transport of substances necessary for cellular maintenance and growth. Passive diffusion. Most drugs pass through membranes by passive diffusion, down their concentration gradient, of the non-ionized moiety. The rate of diffusion depends mainly on the lipid-water partition coefficient rather than on lipid solubility per SE. For example, the central nervous system depressant barbital is almost completely unionized at physiological pH and therefore should be able to cross membranes easily. However, barbital's lipid-water partition coefficient is sufficiently low that diffusion across membranes proceeds at an extremely slow rate. This slow rate of passage across central nervous system, CNS, membranes largely explains why the time of onset latent period, of drug action after barbital administration is delayed. A drug will accumulate in the membrane until the ratio of its concentration in the membrane and its concentration in the extracellular fluid equal its partition coefficient. A concentration gradient is thereby established between the membrane and the intracellular space. This gradient is the driving force for the passive transfer of the drug into the cell. Thus, a drug that has a very high lipid-water partition coefficient will have a large concentration gradient, and this favors its rapid diffusion across the membrane and into the cell. Filtration. The rate of filtration depends both on the existence of a pressure gradient as a driving force and on the size of the compound relative to the size of the pore through which it is to be filtered. In biological systems, the passage of many small water-soluble solutes through aqueous channels in the membrane is accomplished by filtration. The hypothetical diameter of these pores is about 7 a size that generally limits passage to compounds of molecular weight less than 100, example urea, ethylene glycol. Bulk flow. Most substances, lipid-soluble or not, cross the capillary wall at rates that are extremely rapid in comparison with their rates of passage across other body membranes. In fact, the supply of most drugs to the various tissues is limited by blood flow rather than by restraint imposed by the capillary wall. This bulk flow of liquid occurs through intercellular pores and is the major mechanism of passage of drugs across most capillary endothelial membranes, with the exception of those in the CNS. Active transport, the energy-dependent movement of compounds across membranes, most often against their concentration gradient, is referred to as active transport. In general, drugs will not be actively transported unless they sufficiently resemble the endogenous substances, such as sugars, amino acids, nucleic acid precursors, that are the normal substrates for the particular carrier system. This transport involves the reversible binding of the molecule to be transferred to a membrane component, a carrier, of complementary configuration. Several mechanisms of active transport have been postulated. One transport model proposes that the drug molecule combines with a specific mobile carrier, probably a protein, on one side of the membrane. The complex form diffuses across the membrane to the opposite side, where the complex dissociates, thus releasing the drug into the aqueous compartment bordering the opposite membrane surface. The carrier protein can then return to its initial side to bind more drug. Another model involves a chain-like arrangement of sites in transport channels to which the drug can bind. The drug would be transferred from one site to another until it had traversed the membrane. Active transport of a particular substance occur in one direction only. The number of molecules transported per unit of time will reach a maximum, TQ, once the binding capacity of the carrier becomes saturated. Drugs such as levodopa, for Parkinsonism, and N-methyldopa, for hypertension, are actively transported. Since active transport often requires energy in the form of adenosine triphosphate, ATP, compounds, or conditions that inhibit energy production, example iodoacetate, fluoride, cyanide, anaerobiosis, will impair active transport. The transport of a given compound also can be inhibited competitively by the co-administration of other compounds of sufficient structural similarity that they can compete with the first substance for sites on the carrier protein. Facilitated diffusion. The transfer of drugs by facilitated diffusion has many of the characteristics associated with active transport, including being a protein carrier-mediated transport system that shows saturability and selectivity. It differs from active transport, however, in that no energy input is required beyond that necessary to maintain normal cellular function. In facilitated transport, the movement of the transported molecule is from regions of higher to regions of lower concentrations, so the driving force for facilitated transport is the concentration gradient. Although the initial rate of drug transfer will be proportional to the magnitude of the concentration gradient, at some point further increases in drug concentration no longer increase the transport rate, that is, TP has been reached, since the binding sites on the carrier are now completely saturated. Ion pair transport. Absorption of some highly ionized compounds, example sulfonic acids and quaternary ammonium compounds, from the gastrointestinal tract cannot be explained in terms of the transport mechanisms discussed earlier. These compounds are known to penetrate the lipid membrane despite their low lipid-water partition coefficients. It is postulated that these highly lipophobic drugs combine reversibly with such endogenous compounds as mucin in the gastrointestinal lumen, forming neutral ion pair complexes. It is this neutral complex that penetrates the lipid membrane by passive diffusion. Endocytosis. Endocytosis involves the cellular uptake of exogenous molecules or complexes inside plasma membrane-derived vesicles. This process can be divided into two major categories: 1. Adsorptive or phagocytic uptake of particles that have been bound to the membrane surface. 2. Fluid or pinocytotic uptake, in which the particle enters the cell as part of the fluid phase. The solute within the vesicle is released intracellularly, possibly through lysosomal digestion of the vesicle membrane or by intermembrane fusion. Absorption of drugs from the alimentary tract, oral cavity and sublingual absorption. In contrast to absorption from the stomach and intestine, drugs absorbed from the oral cavity enter the general circulation directly. Although the surface area of the oral cavity is small, absorption can be rapid if the drug has a high lipid-water partition coefficient and therefore can readily diffuse through lipid membranes. Since the diffusion process is very rapid for unionized drugs, pK will be a major determinant of the lipid-water partition coefficient for a particular therapeutic agent. For instance, the weak base nicotine, pK 8.5, reaches peak blood levels 4 times faster when absorbed from the mouth, pH 6, where 40 to 50% of the drug is in the unionized form, than from the gastrointestinal tract, pH 1 to 5, where the drug exists mainly in its ionized, protonated, form. Although the oral mucosa is highly vascularized and its epithelial lining is quite thin, drug absorption from the oral cavity is limited. This is due in part to the relatively slow dissolution rate of most solid dosage forms and in part to the difficulty in keeping dissolved drug in contact with the oral mucosa for a sufficient length of time. These difficulties may be overcome if the drug is placed under the tongue, sublingual administration, or between the cheek and gum, buccal cavity, in a formulation that allows rapid tablet dissolution in salivary secretions. The extensive network of blood vessels facilitates rapid drug absorption. Sublingual administration is the route of choice for a drug like nitroglycerin, glyceryl trinitrate, whose coronary vasodilator effects are required quickly in cases of angina. Furthermore, if swallowed, the drug would be absorbed from the gastrointestinal tract and carried to the liver, where nitroglycerin is subject to rapid metabolism and inactivation. Absorption from the stomach. Although the primary function of the stomach is not absorption, its rich blood supply and the contact of its contents with the epithelial lining of the gastric mucosa provide a potential site for drug absorption. However, since stomach emptying time can be altered by many variables, example volume of ingested material, type and viscosity of the ingested meal, body position, psychological state, the extent of gastric absorption will vary from patient to patient as well as at different times within a single individual. The low pH of the gastric contents, pH 1 to 2, may have consequences for absorption because it can dramatically affect the degree of drug ionization. For example, the weak base diazepam, pK 3.3, will be highly protonated in the gastric juice, and consequently, absorption across lipid membranes of the stomach will be particularly slow. On the other hand, the weak acid acetaminophen, pK 9.5, will exist mainly in its unionized form and can more readily diffuse from the stomach into the systemic circulation. Because of the influence of pH on ionization of weak bases, basic drugs may be trapped in the stomach even if they are administered intravenously. Since basic compounds exist primarily in their unionized form in the blood, pH 7.4, they readily diffuse from the blood into the gastric juice. Once in contact with the gastric contents, pH 1-2, they will ionize rapidly, which restricts their diffusibility. At equilibrium, the concentration of the unionized lipid-soluble fraction will be identical on both sides of the gastric membranes, but there will be more total basic drug on the side where ionization is greatest, i.e., in gastric contents. This means of drug accumulation is called ion trapping. Absorption from the small intestine. The epithelial lining of the small intestine is composed of a single layer of cells called enterocytes. It consists of many villi and microvilli and has a complex supply of blood and lymphatic vessels into which digested food and drugs are absorbed. The small intestine, with its large surface area and high blood perfusion rate, has a greater capacity for absorption than does the stomach. Most drug absorption occurs in the proximal jejunum, first 1 to 2 m in humans. Although transfer of drugs across the intestinal wall can occur by facilitated transport, active transport, endocytosis, and filtration, the predominant process for most drugs is diffusion. Thus, the pK of the drug and the pH of the intestinal fluid, pH 5, will strongly influence the rate of drug absorption. While weak acids like phenobarbital, pK 7.4, can be absorbed from the stomach, they are more readily absorbed from the small intestine because of the latter's extensive surface area. Conditions that shorten intestinal transit time, example diarrhea, decrease intestinal drug absorption, while increases in transit time will enhance intestinal absorption by permitting drugs to remain in contact with the intestinal mucosa longer. Although delays in gastric emptying time will increase gastric drug absorption, in general, total drug absorption may actually decrease, since material will not be transferred to the large absorptive surface of the small intestine. Absorption from large intestine. The large intestine has a considerably smaller absorptive surface area than the small intestine, but it may still serve as a site of drug absorption, especially for compounds that have not been completely absorbed from the small intestine. However, little absorption occurs from this site, since the relatively solid nature of the intestinal contents impedes diffusion of the drug from the contents to the mucosa. The most distal portion of the large intestine, the rectum, can be used directly as a site of drug administration. This route is especially useful where the drug may cause gastric irritation, after gastrointestinal surgery, during protracted vomiting, and in uncooperative patients, example children or unconscious ones. Dosage forms include solutions and suppositories. The processes involved in rectal absorption are similar to those described for other sites. Although the surface area available for absorption is not large, absorption can still occur, owing to the extensive vascularity of the rectal mucosa. Drugs absorbed from the rectum largely escape the biotransformation to which orally administered drugs are subject, because a portion of the blood that perfuses the rectum is not delivered directly to the liver, and therefore, rectally administered drug, at least in part, escapes hepatic first-pass metabolism. Factors affecting rate of gastrointestinal absorption. In addition to the lipid-water partition coefficient of drugs, local blood flow, and intestinal surface area, other factors may affect absorption from the gastrointestinal tract. Gastric emptying rate. The rate of gastric emptying markedly influences the rate at which drugs are absorbed, whether they are acids, bases, or neutral substances. In general, factors that accelerate gastric emptying time, thus permitting drugs to reach the large absorptive surface of the small intestine sooner, will increase drug absorption unless the drug is slow to dissolve. A list of physiological, pathological, and pharmacological factors that influence the rate of gastric emptying is provided in Table 1. Intestinal motility. Increased gastrointestinal motility may facilitate drug absorption by thoroughly mixing intestinal contents and thereby bringing the drug into more intimate contact with the mucosal surface. However, the opposite may also occur in that an increase in motility may reduce contact time in the upper portion of the intestine where most of drug absorption occurs. Conversely, a decrease in gastrointestinal motility may promote absorption by increasing contact time. Thus, the effect depends on the drug and change in motility. Serious intestinal diseases, particularly those associated with intestinal sloughing, can be expected to alter drug absorption dramatically. Absorption of most drugs from the gastrointestinal tract is reduced or delayed by the presence of food in the gut. Drugs such as the tetracyclines, which are highly ionized, can complex with Ca ions in membranes, food, or milk, leading to a reduction in their rate of absorption. For drugs that are ionized in the stomach and unionized in the intestine, overall absorption will be delayed by any factor that delays gastric emptying. Finally, increased splanchnic blood flow, as occurs during eating, will increase the rate of drug absorption. Formorphication factors. The ability of solid drug forms to dissolve and the solubility of the individual drug in the highly acidic gastric juice must be considered. For example, although the anticoagulant dicameral has a very high lipid-water partition coefficient, it precipitates at the low pH of gastric juice, and the rate of its absorption is thereby reduced. This may be overcome by covering the tablets with an enteric coating that dissolves only in the relatively alkaline secretions in the small intestine. Drugs administered in aqueous solution are absorbed faster and more completely than tablet or suspension forms. Suspensions of fine particles, microcrystalline, are better absorbed than are those of larger particles. Metabolism and efflux transporters. Drugs may be inactivated in the gastrointestinal tract before they are absorbed. Until recently, only gut microflora were implicated in the metabolism of drugs in the gastrointestinal system, affecting drug absorption. However, it has now become apparent that drug metabolizing enzymes, such as the cytochrome P450 enzymes, play a major role in determining the extent of drug absorption of some drugs. Significant expression of cytochrome P450 3A4 and 3A5 occurs in the enterocytes lining the small intestine. These drug metabolizing enzymes are responsible for approximately 50% of the cytochrome P450-mediated drug metabolism and thus can be expected to play a major role in the pre-systemic metabolism of a number of drugs. For example, less than 20% of a dose of the immunosuppressant cyclosporin reaches the systemic circulation intact. In fact, most of the metabolism of cyclosporin prior to reaching the systemic circulation takes place in the gut via cytochrome P453A4 and 3A5, not in the liver, as might be expected. Thus, gut metabolism is the major factor responsible for the low percentage of an oral dose of cyclosporin reaching the systemic circulation. Cytochrome P452C9 and 2C19 are also expressed in measurable quantities in the human intestine. With any of these four cytochrome P450 enzymes, the variation in expression between individuals is substantial, and so their relative contribution to pre-systemic metabolism of drugs will vary from person to person. Recently, it has also been discovered that efflux transporters, transporters that pump drug or substrate out of a cell, are also present in human intestinal enterocytes on the apical side nearest the lumen of the intestine. The predominant transporter protein identified to date is P-glycoprotein, PGP, which is a product of the MDR1 gene. This transporter was originally identified as being overexpressed in tumor cells and responsible in part for multi-drug resistance because of its role in the efflux of drugs out of tumor cells, thus the name multi-drug resistance, MDR, gene. It has become apparent that many of the drugs that are substrates for cytochrome P453A4 are also substrates for PGP. As a substrate for PGP, a drug will enter the cell, usually via passive diffusion, but then be picked up by the PGP transporter and carried back to the gut lumen, efflux. As this continually occurs along the intestine, some of the drug molecules are prevented from being absorbed, which decreases overall absorption. Taken together, the PGP transporter and the cytochrome P450 enzymes form a mechanism to reduce the amount of drug reaching the systemic circulation. Absorption of drugs from the lung. The lungs serve as a major site of administration for a number of agents given for both local and systemic effects. Such drugs can be inhaled as gases, example volatile anesthetics, or as aerosols, suspended liquid droplets or solid particles. Absorption of agents from the lung is facilitated by the large surface area of the pulmonary alveolar membranes, 50 to 100 square meters, the limited thickness of these membranes, approximately 0.2 y, and the high blood flow to the alveolar region. Pulmonary absorption of volatile anesthetics across the alveolar capillary barrier is very rapid because of the relatively high lipid-water partition coefficients and small molecular radii of such agents. The driving force for diffusion is a combination of the blood-air partition coefficient, which is a measure of the capacity of blood to dissolve drug, and the difference in partial pressure between the alveoli and the arterial and venous blood. Agents with high blood-air partition coefficients require more drug to be dissolved in the blood for equilibrium to be reached. Absorption of drugs through the skin. Most drugs that have been incorporated into creams or ointments are applied to the skin for their local effect. The diffusion rate of a drug through the skin is largely determined by the compound's lipid-water partition coefficient. However, the stratum corneum, or outer layer of the epidermis, forms a barrier against the rapid penetration of most drugs. This is due in large part to the relatively close-packed cellular arrangement and decreased amount of lipid in these cells. Thus, even highly lipid-soluble compounds will be absorbed much more slowly through the skin than from other sites. The dermis, on the other hand, is well supplied with blood and lymph capillaries and therefore is permeable to both lipid-soluble and water-soluble compounds. If penetration of the skin by lipid-insoluble compounds does occur, it is probably accomplished by diffusion through the hair follicles, sweat glands, or sebaceous glands. Absorption of drugs after parenteral administration. Intramuscular and subcutaneous administration. Intramuscular and subcutaneous injections are by far the most common means of parenteral drug administration. Because of the high tissue blood flow and the ability of the injected solution to diffuse laterally, Drug absorption generally is more rapid after intramuscular than after subcutaneous injection. Drug absorption from intramuscular and subcutaneous sites depends on the quantity and composition of the connective tissue, the capillary density, and the rate of vascular perfusion of the area. These factors can be influenced by the co-injection of agents that alter local blood flow, example vasoconstrictors or vasodilators, or by substances that decrease tissue resistance to lateral diffusion, example hyaluronidase. Advantages of the intramuscular and subcutaneous routes include an increased reliability and precision in the drug blood level finally achieved and reasonably rapid absorption and onset of drug action. There are, however, serious disadvantages as well. Pain, tenderness, local tissue necrosis, primarily with highly alkaline injections, microbial contamination, and nerve damage may be associated with these forms of parenteral administration. Intravenous administration. Intravenous drug administration ensures immediate pharmacological response. Problems of absorption are circumvented because the entire quantity of drug enters the vasculature directly. This route is also useful for compounds that are poorly or erratically absorbed, are extremely irritating to tissues, or are rapidly metabolized before or during their absorption from other sites. The rate of injection should be slow enough, however, to prevent excessively high local drug concentrations and to allow for termination of the injection if undesired effects appear. A serious disadvantage of intravenous drug administration becomes clearly apparent when an overdose is inadvertently given. Neither can the drug be removed nor its absorption retarded. Other disadvantages include the possibilities of embolism, particularly if an insoluble drug is given, introduction of bacteria, and when this route is used for prolonged periods, subcutaneous tissue infiltration. The possible introduction of the human immunodeficiency virus, HIV, is a well-known consequence of intravenous drug administration in addicts who use contaminated needles. Factors influencing drugs distribution. Distribution is the delivery of drug from the systemic circulation to tissues. Once a drug has entered the blood compartment, the rate at which it penetrates tissues and other body fluids depends on several factors. These include, 1. Capillary permeability. 2. Blood flow tissue mass ratio, i.e., perfusion rate. 3. Extent of plasma protein and specific organ binding. 4. Regional differences in pH. 5. Transport mechanisms available. 6. The permeability characteristics of specific tissue membranes. Drug delivery and eventual drug equilibration with intercellular tissue spaces are largely determined by the extent of organ blood flow. The composition of the capillary bed is usually not a limiting factor except with the capillaries of the CNS. The renal and hepatic capillaries are especially permeable to the movement of most molecules, except those of particularly large size. The rate of passage of drugs across capillary walls can be influenced by agents that affect capillary permeability, example histamine, or capillary blood flow rate, example norepinephrine. Available distribution volume. The total volume of the fluid compartments of the body into which drugs may be distributed is approximately 40 L in a 70 kg adult. These compartments include plasma water, approximately 10 L, interstitial fluid, 10 L, and the intracellular fluid, 20 L. Total extracellular water is the sum of the plasma and the interstitial water. Factors such as sex, age, edema, pregnancy, and body fat can influence the volume of these various compartments. The rate at which an equilibrium concentration of a drug is reached in the extracellular fluid of a particular tissue will depend on the tissue's perfusion rate. The greater the blood flow, the more rapid the distribution of the drug from the plasma into the interstitial fluid. Thus, a drug will appear in the interstitial fluid of liver, kidney, and brain more rapidly than it will in muscle and skin. Table 2. Binding of drugs to plasma proteins. Most drugs found in the vascular compartment are bound reversibly with one or more of the macromolecules in plasma. Although some drugs simply dissolve in plasma water, most are associated with plasma components such as albumin, globulins, transferrin, ceruloplasmin, glycoproteins, and N and B lipoproteins. While many acidic drugs bind principally to albumin, basic drugs frequently bind to other plasma proteins, such as lipoproteins and acid glycoprotein, NAGP, in addition to albumin. The extent of this binding will influence the drug's distribution and rate of elimination because only the unbound drug can diffuse through the capillary wall, produce its systemic effects, be metabolized, and be excreted. Drugs ordinarily bind to protein in a reversible fashion and in dynamic equilibrium, according to the law of mass action. Since only the unbound, or free, drug diffuses through the capillary walls, extensive binding may decrease the intensity of drug action. The magnitude of this decrease is directly proportional to the fraction of drug bound to plasma protein. At low drug concentrations, the stronger the affinity between the drug and protein, the smaller the fraction that is free. As drug dosage increases, eventually the binding capacity of the protein becomes saturated and any additional drug will remain unbound. The binding of a drug to plasma protein will decrease its effective plasma to tissue concentration gradient, that is, the force that drives the drug out of the circulation, thereby slowing the rate of transfer across the capillary. As the free drug leaves the circulation, the protein-drug complex begins to dissociate and more free drug becomes available for diffusion. Thus, binding does not prevent the drug from reaching its site of action but only retards the rate at which this occurs. Extensive plasma protein binding may prolong drug availability and duration of action. Protein binding also plays a role in the distribution of drugs and thus the volume of distribution. Drugs that are highly bound to plasma proteins may distribute less widely because they remain trapped in the peripheral vasculature, since the plasma proteins themselves cannot traverse into the extravascular space. However, if the affinity of a drug for tissues, example fat, muscle, is greater than the affinity for plasma proteins, widespread distribution can occur despite a high degree of plasma protein binding. Albumin, of the plasma proteins, the most important contributor to drug binding is albumin. Although albumin has a net negative charge at serum pH, it can interact with both positive and negative charges on drugs. Many highly albumin-bound drugs are poorly soluble in water, and for such drugs, binding to hydrophobic sites on albumin is often important. In general, only 1 or 2 molecules of an acidic drug are bound per albumin molecule, whereas basic, positively charged drugs are more weakly bound to a larger number of binding sites. The binding of drugs to plasma protein is usually nonspecific, that is, many drugs may interact with the same binding site. A drug with a higher affinity may displace a drug with weaker affinity. Increases in the non-protein bound drug fraction, i.e., free drug, can theoretically result in an increase in the drug's intensity of pharmacological response, side effects, and potential toxicity. However, in practice, changes in protein binding result in clinically significant effects for only a limited number of drugs. Some disease states, example hyperalbuminemia, hypoalbuminemia, uremia, hyperbilirubinemia, have been associated with changes in plasma protein binding of drugs. For example, in uremic patients the plasma protein binding of certain acidic drugs, example penicillin, sulfonamides, salicylates, and barbiturates, is reduced. Lipoproteins. Drugs that bind to lipoproteins do so by dissolving in the lipid portion of the lipoprotein core. The binding capacity of individual lipoproteins generally depends on their lipid content. It is also possible that the lipid and protein fractions cooperate in the binding process, the drug first binding to a number of sites on the protein moiety and then dissolving in the lipid phase. NB. The importance of AGP as a determinant of the plasma protein binding of basic drugs, including the psychotherapeutic drugs chlorpromazine, imipramine, spiroperidol, and nortriptyline, is becoming apparent. There is evidence of increased plasma AGP levels in certain physiological and pathological conditions, such as injury, stress, surgery, trauma, rheumatoid arthritis, and celiac disease. Selective accumulation of drugs. Drugs will not always be uniformly distributed to and retained by body tissues. The concentrations of some drugs will be either considerably higher or considerably lower in particular tissues than could be predicted on the basis of simple distribution assumptions. This observation is demonstrated in the following examples. 1. Kidney. Since the kidneys receive 20 to 25% of the cardiac output, they will be exposed to a relatively large amount of any systemically administered drug. 2. The kidney also contains a protein, metallothionein, that has a high affinity for metals. This protein is responsible for the renal accumulation of cadmium, lead, and mercury. 3. Several drugs have an affinity for the retinal pigment melanin and thus may accumulate in the eye. Chlorpromazine and other 4. Phenothiazines bind to melanin and accumulate in the uveal tract, where they may cause retinotoxicity. Chloroquine concentration in the eye can be approximately 100 times that found in the liver. 5. Fat. Drugs with extremely high lipid water partition coefficients have a tendency to accumulate in body fat. However, since blood flow to adipose tissue is low, about 3 ml/100 g/minute, distribution into body fat occurs slowly. Drug accumulation in body fat may result either in decreased therapeutic activity owing to the drug's removal from the circulation or in prolonged activity when only low levels of the drug are needed to produce therapeutic effects. In the latter instance, fat depots provide a slow, sustained release of the active drug. Should body fat be seriously reduced, as during starvation, stored compounds, example DDT and chlordane, may be mobilized, and toxic symptoms may ensue. 6. Lung. 7. The lung receives the entire cardiac output, therefore, drug distribution into it is very rapid. Most compounds that accumulate in the lung are basic amines, example antihistamines, imipramine, amphetamine, methadone, phentermine, chlorphentermine, and chlorpromazine, with large lipophilic groups and pK values greater than 8. However, some non-basic amines, such as the herbicide paraquat, also can accumulate in the lung. 7. Bone. Although bone is a relatively inert tissue, it can accumulate such substances as tetracyclines, lead, strontium, and the anti-tumor agent cisplatin. These substances may accumulate in bone by absorption onto the bone crystal surface and eventually be incorporated into the crystal lattice. Tetracycline deposition during odontogenesis may lead to a permanent yellow-brown discoloration of teeth, dysplasia, and poor bone development. Lead can substitute for calcium in the bone crystal lattice, resulting in bone brittleness. Bone may become a reservoir for the slow release of toxic substances, such as lead and cisplatin. Physiological barriers to drug distribution. Blood-brain barrier. The capillary membrane between the plasma and brain cells is much less permeable to water-soluble drugs than is the membrane between plasma and other tissues. Thus, the transfer of drugs into the brain is regulated by the blood-brain barrier. To gain access to the brain from the capillary circulation, drugs must pass through cells rather than between them. Only drugs that have a high lipid water partition coefficient can penetrate the tightly apposed capillary endothelial cells. Drugs that are partially ionized and only moderately lipid-soluble will penetrate at considerably slower rates. Lipid-insoluble or highly ionized drugs will fail to enter the brain in significant amounts. Because the pH of the cerebrospinal fluid is about 7.35, there is some tendency for weak organic bases to concentrate in the cerebrospinal fluid and for weak organic acids to be excluded. In addition, because only the unbound form of a drug is available for diffusion, extensive plasma protein binding also can have dramatic effects on the extent of drug transfer into the brain. Inflammation, such as occurs in bacterial meningitis or encephalitis, may increase the permeability of the blood-brain barrier, permitting the passage of ionized lipid-insoluble compounds, example penicillin and ampicillin, that would otherwise be restricted from penetrating into the brain extracellular fluid. The flow of cerebrospinal fluid is essentially unidirectional, that is, it flows from its site of formation in the choroid plexus through the ventricles to its site of exit at the arachnoid villi. Drugs in this fluid can either enter the brain tissue or be returned to the venous circulation in the bulk flow of cerebrospinal fluid carried through the arachnoid villi. Some drugs, such as penicillin, will not leave the cerebrospinal fluid compartment by bulk flow but will be actively transported by the choroid plexus out of the fluid and back into the blood. Finally, drugs may diffuse from brain tissue directly into blood capillaries. Though drugs appear to cross the blood-brain barrier by passive diffusion, transporter systems in the blood-brain barrier pump drugs back out into the systemic circulation. As in the gut, the PGP transporter system is the primary active transporter in the blood-brain barrier identified to date. This ATP-dependent transporter system picks up substrates that have crossed the capillary endothelial cells and transports them back to the systemic circulation, limiting their penetration into the CNS. Thus, not only are the physicochemical properties of the drug a determinant for penetration into the CNS, but penetration also depends on whether the drug is a substrate for the PGP transporter system. An important consequence of the existence of a variety of routes of drug removal from the brain is that drugs that slowly penetrate the CNS may never achieve adequate therapeutic brain concentrations. Penicillin, for example, is a less effective antibiotic centrally than it is peripherally. Placental barrier. The blood vessels of the fetus and mother are separated by a number of tissue layers that collectively constitute the placental barrier. Drugs that traverse this barrier will reach the fetal circulation. The placental barrier, like the blood-brain barrier, does not prevent transport of all drugs but is selective, and factors that regulate passage of drugs through any membrane, example pK lipid solubility, protein binding, are applicable here. In general, substances that are lipid-soluble cross the placenta with relative ease in accordance with their lipid-water partition coefficient and degree of ionization. Highly polar or ionized drugs do not cross the placenta readily. However, most drugs used in labor and delivery are not highly ionized and will cross. They are generally weak bases with pK values of about 8 and tend to be more ionized in the fetal bloodstream, since the pH of fetal blood is around 7.3 as compared with the maternal blood pH of 7.44. Differences in maternal and fetal blood pH can give rise to unequal concentrations of ionizable drugs in the mother and the fetus. Active efflux transporters also exist in the placenta, analogous to the gut and blood-brain barrier. These are PGP, multi-drug resistance associated protein, MRP, and breast cancer resistance protein, BCRP. These transport proteins are located in many tissues but also appear to be expressed in the placenta. Though the substrate specificities of these proteins have not been completely described, they appear to function as efflux transporters, moving endogenous and exogenous chemicals from the placental cells back to the systemic circulation. In this way, they serve as a mechanism to protect the fetus from exposure to unintended chemicals. Blood-testis barrier. The existence of a barrier between the blood and testes is indicated by the absence of staining in testicular tissue after the intravascular injection of dyes. Morphological studies indicate that the barrier lies beyond the capillary endothelial cells and is most likely to be found at the specialized sertola cell junction. It appears that PGP, the efflux transporter protein, also plays a role in forming this blood-testis barrier. This protein probably plays a role in preventing certain chemotherapeutic agents from reaching specific areas of the testis and thus hinders treatment of the neoplasm.